All happy to see you again. Today we are going to learn about the wound management part 2. Last week we have learned about pressure soap. Mainly we have seen two different types of wounds. One is pressure ulcer and the another one is cancer. In your settings you might have seen different kinds of wounds. But in palliative care, mainly we have seen these two types. Pressure sore we are already learned. Now we are going to learn about cancer root or fungating management. So let me share my slide. So I hope my slide is visible to everyone. Can anyone please confirm? Yes. Okay. So unfortunately, today also we don't have any case presentation. So I have some case scenarios. So we all go through that and then share your thoughts. Okay. So make this session interactive also. So this is the first case scenario. 65-year-old man diagnosed with CA right buccal mucosa, living with his family. He came to your OPD for cleaning and dressing. His main complaints were foul smell and exudation. What could be the possible reason for malodor and how will you manage it? Anybody? Anyone please respond? Metronidazole. So Mamda said metronidazole crush and sprinkle. Okay, so that is the management. Okay. What could be the possible reason for malodor? Any thoughts? Anybody? Prince, please respond your thoughts. Preeti Sahu, are you there? Salim, Sunita, are you there? Shani ma'am, are you there?
Yes, I'm listening. I don't have experience in palliative care. This is my first exposure. So I do not know how to answer this. Sorry.
Okay, okay. So I'll come to that later. Thank you for the answers. So this is the definition. The fungating wound is a primary or secondary malignant growth in the skin, which is ulcerated and difficult to heal. So the term fungating refers to a malignant process involving both ulceration and proliferative growth. So it could be, it looked like a nodular fungus or a cauliflower in shape. So we used to call this wound is fungating wound. It's not because of fungal infection. It looked like a nodular fungus shape or a cauliflower in shape. So this wound is not able to heal. The major difference between pressure ulcer and fungating wound is pressure sore is preventable and curable. This is not preventable and not curable. So this is the major difference between punctuating wound and cancer, the pressure ulcer. So here also, day by day, the tissue necrosis will increase. If there is a necrotic tissue there, definitely malodor will be formed. So these are the some causes of malodor formation. So what you have to understand is this wound not able to keep. So we can able to control this kind of wound symptoms and improve the quality of life of the patient. Coming to the pathophysiology, so we all know that develop a non-tender skin nodules initially, but in cancer, that nodules enlarge, and then if the nodules enlarge, that leads to destruction of capillaries and lymph vessels. If this happening, then altered coagulation, disorganized circulation, followed by tissue hypoxia and necrosis. So this is the pathophysiology of cancer wound. So I don't know how many of you heard about Marjolin ulcer. So this is a type of malignancy of the skin. Malignant changes in the chronic wound. So example, burn scar ulcer, pressure ulcer, and venous leg ulcer. So these are some of the examples of chronic wounds. So that in that chronic wound, development of cancer, the pathophysiology is little bit different. Here, appearance of mass in the wound, not previously present. But because when we open the wound, we think like, okay, maybe granulation tissues is there. So not like that. There is a mass in the wound, but the patient will be complaining of pain, not previously present. When you touch that tissue, the patient will be complaining of pain. And the next thing is the own appearance, character, volume, these all will change because not previously present. Previously, exudate will be there, but if the patient develop cancer, the exudate, the quantity will increase. Okay, so these kind of changes will be there. If you notice these kind of changes, better you can refer the patient to the oncologist or surgeon and make sure that whether the patient is having any marginal ulcer or not. If the patient is having marginal ulcer, that patient needs to take a curative management. This is one of the curative possible cancer. So if you find these kind of symptoms, better you refer the patient to the oncologist. Coming to the problems, there are physical problems, psychological problems, social problems, and spiritual problems. Because just from the beginning also, you have learned about long-term management, total care. So is a life-threatening illness or life-limiting illness. These all terms you heard from the first session onwards. Here also you have to understand that this is a non-healing ulcer. The patient will go through a lot of problems because there will be lot of physical problems, lot of psychosocial issues, social problems, and spiritual problems. So we are the persons to listen their problems and also try to control their problems. So we all know that why they come to us. They try all non-pharmacological measures, and then that non-pharmacological measures fail, they'll come to us. So they are expecting from us a better care. So always you have to keep it in mind, especially nurses. We are the persons spend more time with the patient. So you are the person to be a good listener. You will get enough time to listen their problems. If you make a good relationship with the patient, definitely you can able to explore many things. So I'll I'll go through one by one: physical, psychological, social, and spiritual. And this is another case scenario. 50-year-old man diagnosed with the cancer right buccal mucosa, living with his family. He came to your OPD for cleaning and dressing. The same patient. His main complaint is bleeding and pain while removing the dressings. What could be the problem? Before moving to the physical problems, I would expect answers from the group. So this is this patient problem. Just imagine this is not is one of the wound. It's not a cancer wound. Any wound can develop these kind of problems. His main complaint is bleeding and pain while removing the dressings. What could be the problem?
I have a hypothesis. Can I answer?
Yes, ma'am.
I feel this patient had a bad previous dressing experience. If the dressing was not soaked well before undressing, opening the dressing, the patient had bleeding and pain. He's anticipating the same now. It's possible. I'm not sure. It is possible.
Yes. Yeah. Thank you, ma'am. Thank you. Any other opinions? Okay. So what we need to understand is the dressings are adherence to the wound. As Shani ma'am said, before soaking the dressing, the all dressings, if you try to remove, the patient may feel pain and bleed. Definitely they feel pain, but after that bleeding will be there. So it's our duty to soak the wound well, soak the dressing, all dressing well, and then remove it so that we can able to prevent pain and bleeding. So coming to the physical problems and psychological problems. So one of the most common physical problem is pain. So these are some physical problems, pain, because you already learned about two different types of pain, nociceptive pain and neuropathic pain. Here, these patients can develop two different types of pain because one is direct exposure of the dermis can cause nociceptive pain. Sometimes the tumor will be compressing to the nerves or blood vessels. That time the patient will experience neuropathic pain. So nociceptive pain and neuropathic pain can develop. So you have to assess well. If the patient is complaining of pain, you have to assess whether the patient is having nociceptive pain or neuropathic pain. If the patient is having nociceptive pain and neuropathic pain, you have to give a proper treatment. If you treat a nociceptive pain alone, the patient will not get adequate pain relief. So that is one of the most important part. And the next thing is malodor and also pain while removing the dressing. If you not soak well, the patients might have developed pain also. So because of the dressing, the own adherence. So that also you have to keep it in mind. The next thing is malodor. So malodor is the first case scenario was the malodor. The main problem was malodor. So here, lot of necrotic tissues, devitalized necrotic tissues within the tumor can cause malodor. And the next cause is stale X-ray dressings have been placed in number of days. The patient is not able to change the dressings every day. Maybe the last 3 days the same dressing was there. So definitely the patients from that too you will experience bad smell. So malodor is there, and then bleeding. Bleeding again One is because of that improper dressing techniques, and the another problem is the major tumor. The tumor will be protruding the blood vessels. Okay, so that is the another major the cause of bleeding. So if the patient is having head and neck cancers, so there is a more chance of bleeding. So you have to prepare the patient family for the same. If there is accident and bleeding there, how they will manage? You have to prepare the patient family. And exudate. What is exudate? Exudate is oozing out of lot of fluid from the purulent discharge or fluid-like substance from the wound. That is exudate. This will be affecting the patient and family members also. Again, all malodor and exudate will be affecting the patient and also affecting the family members, because nobody is willing to sit near to the patients because of the small malodor. They will not allow the patient to come outside the room. So they will keep the patient always in the room. So that will be affecting the patient emotional problems. Okay, because of my problems, my family members or my daughter, my son is not allowing me to come out of the room. So the family isolation will be there, and itching. Very rarely itching, because the accident will be touching the normal each day. And another then the margins around the fungating node, there is a small that nodule like the things will emerge. So that time some kind of chemical reaction will be there. Then the patient may feel itching. So and then infestation with maggots. So very rarely maggots. How does maggots come? Can anyone say how does maggots come?
Through the flies?
Very good. Any other answers? Very good, ma'am. Any other answers? Any other answers? Shani ma'am said it's come from flies. Any other opinion?
Unclean hands while doing dressing. I'm not talking about nurses. I'm saying even it could be family members or others.
Okay. Thank you, ma'am. Others, please respond. So the maggots are come from house flies. As ma'am said, how the house flies. So if there is an infected wounds there, the usually the house flies are attracted. If when they touch the wound, they may lay eggs. So within 8 to 12 hours, come out with maggots. So it's our duty to educate the patient for covering the wounds properly. So that is very, very important. And communication difficulties, especially head and neck cancer patients, not able to talk their problems. So if they are able to write down their problems, you can give a sheet of paper and ask them to write down their problems. Okay, then you will get a good idea about their problems. Otherwise, you have to go to their non-verbal expressions. Okay, if they are not able to write down, then you can use your non-verbal language. And psychological altered body image. So that is also the one of the major emotional things. We all know that one small pimple in your face, so that gradually the size is increased. What we will do usually, if we get a chance to see that pimple in the mirror, how many times you go there and see? whether the size is increasing or decreasing, these all things will be there, no? So that is the normal response. Just imagine this is a non-healing ulcer in the face. Day by day, the size will be increasing. This will be affecting their daily activities. This will be affecting others too. Because of that, the emotional problem will increase. And sexuality, maybe because of misconception, the disease will be spreading to others too. That kind of misconception will be there. Denial will be there. Some positive denial and negative denial will be there. Sometimes they know this wound is not going to heal, but even then they will argue. So my wound is healing well, isn't it, sister? These kind of things will be there. But what you have to do is you have to listen, not take as a challenge and make him or her understand this wound is not at all healed well. You have to understand that. But if they say it like says like that, it's our duty to listen and give an empathetic, show an empathetic expression, like emotional expression. So we know this is not going to heal, but we are now just to give a pause, and then gradually they will understand that the symptoms will increase, the wound size will increase. That time they will understand my wound is not healing well. So usually this kind of positive denial will be there. If there is a positive denial there, just listen and give him or her alone. Then send him or her alone, and then after 2 weeks they will understand. 2 or 3 weeks they will understand. If there is a negative denial there, you just explore their emotional problem, just explore their insight, and if you understand there is a need to communicating the bad news to the patient, then you can use the spikes protocol. Okay, coming the next thing is fear. Fear is also they will be afraid about this, because now what is next, these kind of things, maybe their friends or maybe relatives uh, had maybe they have a past history like this, maybe experience like this, or this maybe that will be affecting them a lot. Depression and anxiety will be there. What is going to be next? So what is next? These kind of questions will be there. Shame will be there. They will be in guilt because of sometimes they used to do have a maybe habit of smoking there. Maybe because of that, that guilt will be there all the time. Because of that only I got this kind of disease. So what we can do is just be a good listener. No need to blame because of that only you got this kind of disease. So these kind of, so maybe the disease is anyway cancer is cancer, not able to, we all know that we are not able to cure that problems. Now he or she is going to lot of problems. Uh, just be a good listener. And coming to the social family isolation, so usually if one person get a disease like this, the family members will choose a corner side room and keep the patient there. So they are not willing to enter into the, they are not allowing the patient to enter into the dining area or open wall anywhere. They always, they will give a proper instruction to the patient. You have to be in the room all the time. We will give all food and all things there. Okay. Shani ma'am, any questions?
No, I don't have any question. Don't call me ma'am, please.
So then coming family isolation, then social isolation. Then again, just think about the social. Sometimes before disease, there were many friends or relatives. They used to visit. They used to travel with him. But after this disease, nobody is willing to see him. Maybe misconception of disease. This will be affecting the patient a lot because of my disease. My friends and relatives are not willing to see me, not willing to come to my house. So these kind of things will be affecting the patient a lot. Social stigma, fear of contagion, and effects on family. So this will be affecting the patient a lot because and sexual relationship, marital disharmony because nobody is willing to get married from this kind of family because of the hereditary issues. So this will be affecting the patient a lot because of me only, because of my problem, my daughter is not getting married. So these will be affecting the patient emotionally. Coming to the spiritual interference with the religious rites because of my sin, God punished me like this. These kind of spiritual problems will be there. So what we can do is how to do the proper assessment. And another important things you have to keep it in mind while doing the assessment is in front of the caregivers, they will not give a truth. They always hide the truth in front of the caregivers. Okay, if possible, you can do the individual assessment. If you can able to individual assessment, they can able to explore well their problems. Sometimes the family members will they are not willing to take care of the patient. Also you can understand if you do the individual assessment. Otherwise always says like, okay, my family members take care of me well, these kind of things will be saying like. So we have many experience like this in front of caregivers. They used to tell us like, oh, my daughter-in-law or my daughter is take care of me well. So after that, if we do the individual assessment, they will start, right? Because nobody is willing to sit near to me, nobody is willing to take any the food items from me. So these kind of things will be affecting the patient emotionally. So if we notice, if you can understand these kind of problems in the family, better you can talk to the patient family and explore their inside also. Sometimes misconception of disease is also there. So you make them understand that this is not going to spread. So if there is any misconception there, you have to convey the. And coming to the assessment, you have to do the assessment on wound location because is a mobility, is there any mobility environment they are easily covered with a public view. So this is very, very important because I have one patient, he used to bring he used to come for dressing every day. So usually he used to bring a big towel with him always. So I asked one day, why did you bring this big towel all days? So then he told me, I need this one. Otherwise, I won't be able to go outside. I asked him again why, what happened? Is there any problem? Then he told me like he used to travel by bus. After the dressing, he used to cover. He is having see a buccal mucosa. He used to after the dressing, see he always says like how to cut the edges also. I need to cover this cover the wound properly. So please cover the edges also. Then I said, okay, I will cover. I will cut short the edges and all. So after the dressings, he used to take his big towel and cover like this. So then he will go back to his home. As I mentioned earlier, we used to travel by bus. If the wound is open, the dressing is open, nobody is willing to sit near to him. If he is covered the wound with this towel, nobody's see that wound is inside the towel. Externally is not visible, so they will sit near to me and travel. So this will be affecting the patient a lot. Because of my problem, nobody is willing to sit near to me. Okay, so this is a coping mechanism he used to do. Bring a big towel with him always. And wound appearance, surrounding skin, and potential for complications. So that is also important because especially head and neck cancers, if there is a chance of bleeding, you have to prepare the patient well because prepare the patient and family well. If there is a sudden bleeding, profuse bleeding there, they have to manage in their home. Coming to the management, principles of management, palliation of symptoms, our aim is to reduce the symptoms. If we can able to reduce the symptoms, we can able to improve the quality of life of the patient and their family. So these are the common symptoms. Pain. If the patient is having pain, give us some analgesics and give proper pain management. So pain relief, and so that the patients can able to walk or can able to speak. So if the patient is having pain, they are not able to take anything, take food. They are not able to sleep well. They are not able to get out from the bed. So these all affecting the patient physically. So as much as possible, try to reduce their problems, especially pain. Controlling odor and infection, again, that is also have to do. Managing exudate, minimizing bleeding, holistic care. So this patient need a holistic care, that is total care. So we always see the physical part only, but you have to look into the other aspects also because palliative care is for the palliative care. From the palliative care, you learned about the importance of total care, the total pain aspects. So this patient need a holistic care. Always you have to empower the patient and family in own care. Criteria for wound dressing is a goal of care is to maintain or improve the quality of life through symptom control. Okay, and we need an empathetic mind to treat. So because there are a lot of problems, we have to what we have to do. What is empathy? What is empathy? Can anyone say what is empathy? We learned about empathy, Dacton boys in the nursing school itself. It's one of the quality of nurse. We don't want any sympathy. We need an empathetic mind. What is empathy? Anyone, please? So, empathy is putting ourselves into their shoes. Is that place? Understanding the person as if he is in the shoes. So you have to put yourself into their shoes. Have to think from the patient side. From you, if you are there, if your uncle is there, how will you treat? So that is the empathetic. So you need an empathetic mind to treat this kind of patients. Provide a thorough bath before dressing. If possible, educate the patient to take a thorough bath because these kind of wounds are fragile. So if you give more pressure on that wound, may start bleeding. So there are a lot of necrotic tissues in the wound. If they are able to take bath, all necrotic tissues will follow. So after that, you can clean with normal saline and put metronidazole and cover the dressing. So before dressings, you have to ensure that the patient is pain-free or not. If the patient is having pain, you can give some analgesics for that. and wait for another. If you give a systemic analgesics, you can wait for another 45 minutes and make sure that the patient is getting anti pain relief, and then you can do the dressing. If the patient is having neuropathic pain, then you can take some, you can give some local anesthetic agent, and within 10 minutes the patient will get a local anesthetic effect. Then you can do the dressing and use normal saline for wound dressing. Select dressings based on the exudate, based on the size of the wound and exudate level of the wound. Coming to the minimizing the pain. So there are two different types of wounds, as I mentioned earlier. So deep pain, like systemic, like nociceptive pain, aching, staping, continuous, this kind of pain is an example of nociceptive pain. So if there is a nociceptive pain there, your systemic analgesics will help. Then you can give some systemic analgesics. Or if the patient is on morphine, 10 milligram per hour early, before dressings, you have to ask them if the patient is having pain, give an extra dose, and then wait for another 45 minutes, and then you can do the dressing. If the patient is having neuropathic pain, your systemic analgesics will not help. Then you can think about the sensor pain and hypnopain. So you can take 1 ml and add 2 ml of normal saline, and then you can push into the wound, and then you can take a syringe for that, and then you can push into the wound, and then that within 10 minutes the patient will get a local anesthetic effect, so that you can able to do the dressings without pain. Coming to the malodor, daily dressing. So, because of two major cause of malodor, one is because of devitalized necrotic tissues within the wound can cause malodor. So, we have to do the proper cleaning and dressing with normal saline. So, after that, you can apply metronidazole powder. So, metronidazole ointment is also available, but the thing is little expensive. Better you can use it, tab metronidazole and make it a powdered form and sprinkle on the wound. And the next thing is injection metronidazole irrigation. So these kind of wounds are a lot of pocket formation is there, because if you if you apply metronidazole powder, it will not go inside. There will be lot of pocket like formation will be there. So that time the injection metronidazole will help to go inside, and that way we can able to control the malodor. And you can try on course of systemic analgesics, but the thing is externally, the superficially, the blood supply is not good. That time the antibiotics will not help, but you can try one course of antibiotics. And the next thing is charcoal powder. And you can keep charcoal pieces under the bed of the patient, or keep it in the corner of the room. So that is one of the good agent for controlling malodor. Okay, so otherwise you can take the charcoal powder, and first you can make a charcoal powder, and take a dressing pad, apply one thin layer of Vaseline, and put some charcoal powder on that, and again you can place a one dressing pad, and then you can cover the wound. Okay, so like a sandwich, in between there is a layer of charcoal, so that way we can able to control the bad smell. So here also no hydrogen peroxide and betadine. If you apply hydrogen peroxide to this wound, so again the patient will experience irritations, and the patient may feel pain also. So this is not able to control. You are not able to cure. So again, there is no use of this hydrogen peroxide. If you use hydrogen peroxide like this, hypochlorite solutions like this, that will create another problems. So especially irritation. So this is the next case scenario. Miss S is 68-year-old lady with a metastatic squamous cell carcinoma of the tongue and a large neck malignant lymph node mass, which appears to be about to erode and carotid artery on the recent imaging. There are no further surgical or oncological treatment options, and the patient has now been given a poor prognosis due to an advanced nature of her disease. The possibility of a terminal hemorrhage has been raised by clinical staff. As a home care nurse, what is your first action when you attend the patient and find that she is having a massive hemorrhage? If the patient is having this kind of bleeding, what is you are in the home, no medications, nothing.
Isn't this a medical emergency situation?
Yes, this is one of the palliative care emergency, ma'am. Sorry, again, ma'am. Okay. Any other answers? Others, please respond. I would like to hear from you all. Binder, please respond. If you are a home care nurse, how will you respond? Priti said call for medical help. Okay. This is advanced cancer. So, terminal hemorrhage. They already understand that the prognosis also we explain well. But when we go for a home visits, this is the situation. Pressure application. Okay. Then so the important thing is always try to prevent. Okay, so always coming for the bleeding part, always try to prevent. Like we as we discussed earlier, if there is usually the wounds are the dressings are adherence to the wound. If you are not soft well, there is a chance of bleeding. So that way you have to prevent it. You have to soft well before removing the dressing. So you always try to prevent it, but if the bleeding is there, give a local pressure, and then you can apply sucralfate powder as we the same tablets which we are using for peptic ulcer management. So that is that medications can have another effect also. You can, if you have that medication, you can crush it and make it a powdered form and apply it, and then you can go with the tranexamic acid. Again, you can make it a powdered form and apply superficially, and then if these measures fail, then you can go their systemic ethoxylate. And then you have to think about palliative radiotherapy. So another important thing is dark color clothes. If someone's developed profuse hemorrhage, especially terminal hemorrhage, terminal cancer patients, they all know that. Then you have to think about the dark color clothes. You have to tell the caregivers if there is accidental hemorrhage there, you have to use the dark color cloth for wiping out the blood. Because if you use a white color cloth, what happens? That bright red color will be there. The color will be again the patient the patient will be in anxious, the neighbors will be in anxious, the people around the patient will be in anxious, and it may be creating a panic shock also. So always you have to tell the patient family to keep dark color clothes. So that is one of the important part you have to learn from this bleeding part. Other that other management you all know that except sucralfate powder. Always try to prevent if there is bleeding there, given local pressure, and you can use a dark color cloth for wiping the blood. So these are the role of cancer therapy, radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery. So these will help to strengthen the size of the tumor. So surgery, there is a debulk surgery. If the patient's health status is okay, then you can think about that. Here also, if the patient's health status is okay, there is no metastasis there, then you have to think about the radiotherapy, cytotoxic chemotherapy, hormone therapy, and all. So if you do this, that will help to strengthen the size of the tumor. That leads to we can prevent bleeding occurrence, because they will another 2 more months they will be living like without any problems, because the maybe because of the tumor size, the tumor will be protruding the blood vessels, no, so that we can able to control, we can able to shrink. Coming to the maggots management, always have to prevent. We already discussed, it's come from house flies. The infected wounds are attracted with the house flies. If they touch the wounds, they may lay eggs. After that, if you do the proper cleaning and dressings, it won't affect. Otherwise, the patients will develop maggots. That wound will develop from the wound. You can see the maggots. So, if the patient is having maggots, you can use turpentine oil. Take a turpentine, not pour directly. That again irritating the wound, and also especially head and neck cancers. The patients have developed breathing problems also. Better you can take a turpentine oil into the gauze piece or a dressing bag, squeeze out of excess turpentine oil and keep close to the wound. So that time the maggots will come out. Okay, so that time you can, when they come out, you can take it out with the help of artery forceps. Put it in the hot water. Okay, and another important things I want to give you here is, you have to keep it in mind always is, don't follow maggots. Don't follow maggots. When you go with your artery forceps, they go inside and keep safe there. Okay, because there are lot of pocket formation inside the wound. They go inside and keep safe. They will be safe inside. When you go with your artery forceps, what happens? Your artery forceps will rupture the blood vessels. When they come out, you can take it out. Otherwise, you can leave it, and within a minute, they will again come outside. So that time you can take it out. So that important things you have to keep it in mind all the time. Thank you. Any questions? Any questions?
I have a question.
Yes, ma'am.
Especially home care. I've heard many places especially the Government of India manuals, they use cotton or soft cotton cloth and all these things I have read. Is it appropriate to use them? The sterilization of the equipment. I know it's beyond the scope of this class. Can you highlight, Sheeba, on that?
Yes, yes. You can use dressing materials or cotton clothes, because sometimes, usually the palliative care team centers will be providing the dressing materials. If that dressing material is finished, if they are not able to buy the dressing materials, so what is the home remedy? You have to teach some home remedies also, especially homemade, how to make homemade saline and dressing materials also. If they have a good the cotton dhotis or sari there, they can cut into squares and steam them. At least 12, half an hour steam them.
You
So,
said steam them, right?
steam. Idli vessel, no? You can put it in the idli vessel and steam them. I'll show you. I have a video on that. I'll show you. So then you will get a good idea.
How frequent? I have another follow-up question. How frequently for home visit patients we can do the dressing when we have a mobile service? Because I heard some places, I mean, I don't have direct experience. I'm yet to check out on this. How frequently we can or we need to do the dressing?
Yeah, ideally they have to do at least once in a day. If they have a, because these kind of wounds have developed lot of exudates and malodor, they that time they have to change 2 times or 3 times a day. Better you have to prepare the patient family for dressing. We usually, initially they have some reluctancy will be there. They will not accept. They usually said like, I don't want to do this dressing. I won't be able to do these kind of dressings. I want to able to see this kind of food. These kinds of response will be there. What we do is we usually bring the patient and caregivers here in our inpatient department, and our nurses will show them, and initially we request them to see the dressing, wound dressing. Just be a few days they will be an observer, and then they will see the wound, and then our nurses will telling like, okay, can you pour some normal saline? Then they will help, they will start helping. Give, they will take a normal saline bottle and pour some normal saline into the wound. So there is an involvement there. Then gradually our nurses will that involving the dressings. They will do the dressings in front of our nurses, and then they will get a confidence, and then they will discharge the patients. After that, every 2 weeks, our home care teams will visit the patient.
So this involving preparing the family is starting at the hospital, right?
Usually, but if they are not able to come to the hospital, you can do the video call and teach them at least once. You can go there and teach. This is how. Yes, demonstration is mandatory. That is very important, because they don't know how to do the dressings. Better you can at least one day go there and demonstrate the wound management, and then you can do the video call and educate them. But depends upon the wound's condition, the frequency of change, the dressings change is there. So because some wounds will have a lot of exudates, some wounds less exudates will it. If there is less exudates there, then once in a day is enough. But if there is a lot of exudate there, you have to change the dressings maybe 3 times a day or 2 times a day. So that is based, depends upon the wound condition. Any other questions? And video on dressing materials preparation.
I need help. Yeah, I need help. If you have any articles regarding what to say, this study on this homemade dressing and saline, can you share it with us?
Yes, sure.
Yeah, thank you so much.
Any other questions or comments? Ma'am, do you have any questions? Suman? So if you don't have any questions, we can wind up. Because if we have a case presentation, we can discuss. Otherwise, uh, that is why we keep it 1 hour presentation and half an hour patient story presentation. So if we don't have a case presentation, we can wind up. So any questions or comments? Anything? Any questions in the chat? So again, Chanimam is asking about injectable or applied to the wound before dressing. So for pain management, you can use cyclocaine injection, that sensorcaine injection or cyclocaine. Both you can use now. Any other questions in the chat? No, nothing, no? Okay, thank you so much. We can wind up.
Thank you, Sheeba ma'am, for the wonderful session. Thank you all for participating. Thank you, everyone. Let's see in the next section.